Hello friends, welcome to my YouTube channel Pathology Academy. I am Dr. Aditi Kumar and today I will be discussing about approach to benign lesions in a lymph node. So while evaluating lymphadenopathy, a biopsy is often performed if there is uncertainty in the diagnosis after history, physical examination, imaging, and laboratory workup. The approach to biopsy for benign lesions should be methodical and minimally invasive whenever possible. The indications for biopsy, however, include persistent lymphadenopathy for more than 4 to 6 weeks, enlarging lymph nodes, no response to treatment, systemic symptoms like fever, night sweat, weight loss are present despite initial benign impression, and unclear diagnosis after non-invasive workup. In pre-biopsy evaluation, proper history is taken for any exposure to recent infections or any history of autoimmune disease or any drug intake or occupational or environmental exposure to anything. All this has to be accounted for in history taking. In physical examination, the location of the lymph node, the numbers of the lymph node, the size of the lymph node, whether it is tender or not, consistency of the lymph node, mobility of the lymph node, etc., should be gathered. An investigation, blood investigations like CBC, ESR, CRP, LDH, serologies, if required for Epstein-Barr virus, CMV, and HIV, etc., should be performed. Imaging test, ultrasound is the first line for superficial nodes, and CT/MRI for deep or mediastinal lymph nodes. PET scan is usually done for malignancy workup but can help in difficult cases. Now, what are the types of biopsies we can perform? We can perform a fine needle aspiration biopsy that is with minimally invasive and it is usually done in an outpatient department and it's good for initial assessment. Limitation is that it may miss architectural features needed for diagnosis and is not ideal for lymphoma suspicion. Then another thing is core needle biopsy, which is image guided and provides tissue architecture. It has a better diagnostic yield than FNA, especially for granulomatous disease like tuberculosis, sarcoidosis, or reactive hyperplasia. However, may still be limited for lymphoma diagnosis. Excisional biopsy is gold standard if lymphoma is a concern or prior biopsies are inconclusive. Entire lymph node is removed for histopathological examination and it allows full architectural examination, typically used when persistently enlarging lymph node or high suspicion of malignancy or deep tissue sampling is required. So here I will be discussing about some common benign pathologies on lymph node biopsy like reactive lymphoid hyperplasia, granulomatous inflammation in tuberculosis or sarcoidosis, Kikuchi disease, Castleman disease, infections, lymphadenitis, and autoimmune related lymphadenopathy. Reactive lymph node hyperplasia is the most common benign finding. It represents a non specific immune response to infection, inflammation, or antigenic stimulation. Histological features are that the architecture is preserved. Prominent germinal centers in lymphoid follicles are noted. Mixed small and large lymphocytes with tangible body macrophages are seen. And in cases of viral infections, paracortical hyperplasia, which is a T cell zone expansion, is noted. It should be differentiated from follicular lymphoma. In follicular hyperplasia, there are well spaced lymphoid follicles, mantle zones are well preserved, frequent mitosis and tangible body macrophages are noted, and germinal centers often are polarized. However, in follicular lymphoma, there is back to back arrangement of follicles with diminished mantle zones to absent mantle zones, less frequent mitosis. Exception is high grade lymphomas, less frequent tangible body macrophages. Granulomatous lymphadenitis, especially in cases of tuberculosis, sarcoidosis, any fungus or foreign body infections, can be seen. In tuberculosis, there is central caseating necrosis surrounded by epithelioid histiocytes and Langerhans giant cells with a peripheral rim of lymphocytes. And we can use Zeal-Nielsen stain to detect the acid-fast bacilli. In sarcoidosis, there is a non-caseating granulomas are present, tight clusters of epithelioid histiocytes and multinucleated giant cell. Asteroid bodies or Schaumann bodies may be seen, and there is no central necrosis. In fungal infections, for example, histoplasmosis, granulomas may be caseating or non caseating, and special stains like GMS or PAS stain can be used to identify fungal organisms. Here, I have given you a touch preparation image of the lymph node where you can identify the fungal organism, which are pinpoint and pink colored in the first image. And in the second image, you can see the special stain, GMS stain, where you can note the brownish black colored histoplasma fungal organisms. In viral lymphadenitis, which could be because of Epstein-Barr virus infection or HIV infection or CMV infection, you can see features like paracortical or T-zone hyperplasia, immunoblast and plasmacytoid lymphocytes. Follicular hyperplasia may also be seen in EBV. There is large atypical lymphoid cells seen in the blood, which are known as Downy cells. Kikuchi disease or Kikuchi Fujimoto disease, which is also known as histiocytic necrotizing lephanitis, typically affects young women. It can be confused often with lymphoma or SLE. However, histologically, in cases of Kikuchi disease, we see patchy necrosis in paracortex without neutrophils, karyorectic debris, abundant concentric histiocytes, and no granulomas. In cat scratch disease, which is caused by Bartonella henselae, histologically suppurative granulomas with central areas of necrosis and neutrophils, peripheral palisading histiocytes can be seen, and Warden studies stain may show the organism. Toxoplasmosis is caused by Toxoplasma gondii, which is a protozoa. In this, there is often cervical lymphadenopathy present in patients, and on histology, you can see follicular hyperplasia, prominent epithelioid clusters in the germinal centers, and monocytoid B cells in the sinuses. In autoimmune lymphadenopathy, for example, in cases of SLE or systemic lupus erythematosus, features like necrosis with hematoxylin bodies are seen, plasma cell infiltration is seen, and it may resemble Kikuchi disease, but there is presence of plasma cells and hematoxylin bodies. Castleman disease can histopathologically have three types of presentation: hyaline vascular type, plasma cell type, and mixed type. In hyaline vascular type, which is the most common type, follicles are small, atrophic germinal centers with hyalinized vessels are seen. Lollipop appearance is noted as vessels are penetrating the germinal center. Mantle zones are expanded with concentric rings of small lymphocytes, giving it a onion skin appearance. An interfollicular region shows increased capillaries with endothelial proliferation. The plasma cells are usually sparse. In plasma cell types, follicles are hyperplastic, less hyalinized than HB type. Interfollicular region shows sheets of mature plasma cells, and vascular proliferation is less prominent than HB type. Mixed type features of both HV and PC types in the same node is present. So, to summarize, in reactive hyperplasia, polyclonal germinal centers and preserved architecture is noted. In tuberculosis, caseating granulomas with Langhans type of giant cells are seen, and you can do a Zeal-Nelson stain to see for acid-fast bacilli. Sarcoidosis, you see non-caseating granulomas and asteroid bodies could be seen. In viral lymphadenitis, paracortical hyperplasia with presence of immunoblasts is seen. In Kikuchi disease, necrosis, karyorrhexis, concentric histiocytes are seen, but there is no neutrophils. In cat scratch disease, there is suppurative granuloma and Warden-Starry stain is positive. In toxoplasmosis, follicular hyperplasia, epithelioid clusters in germinal centers, and in SLE, hematoxylin bodies, necrosis, and plasma cells is seen. So, what is the immunohistochemistry scenario in a benign lymph node? In a biopsy of a reactive lymph node, CD20 labels the B cell follicles and mantle zones, CD3 labels the T cell zones of the paracortex, BCL2 is negative or weak in the germinal centers, CD21 shows an intact follicular dendritic cell network, Ki67 is concentrated in germinal centers with expected zonation, no aberrant co expression or loss of lineage markers is noted. And now let's talk about some practical tips and diagnostic pitfalls. While always assess the overall architecture before focusing on cell level detail, alveolus like follicles, intact sinuses, orderly zones argue for benign. Beware of burned out or sclerotic reactive nodes where architecture is subtly distorted but not fully effaced. Some benign lymph nodes, especially post-viral or immunological stimulation, may show large immunoblast or atypical cells. This can be misinterpreted as lymphoma if context is not considered. Follicular lymphoma often has monomorphic, closely packed follicles and BCL2 positivity in germinal centers. This contrasts with the reactive follicles that are pleomorphic, polarized, and BCL2 negative. Always correlate with clinical imaging and laboratory findings. The pathology rarely stands alone. You have to always have a correlation of clinical imaging, laboratory findings. So, signs of infection, viral serology, imaging features, whatever is required, ask for it, and then you correlate and come to the diagnosis. And if there is any doubt, review with hematopathologist or send for ancillary testing or second opinion.